Medical Device Innovation Center in Buffalo, New York. The JI, or the Jacobs Institute, is proud to welcome you to the third webinar in our series, An Expedited Pathway to Tavr, Protecting the Patient and the Providers During the COVID Pandemic. This series has been generously funded with an education grant from Edwards Life Sciences. All 4 webinars in the series will be moderated by Dr. Vijay Iyer, and each will highlight the best practices that each center, all participants in the Edwards Life Sciences Benchmark Program, have used to address the challenges posed by the COVID-19 pandemic. The final webinar will be next week with Dr. Ali and his team at Novant Health Presbyterian Medical Center at 4 p.m. on December 14th. So please join us for that as well. I will turn Dr. Iyer's introduction and that of the other panelists over to the JI's Director of Training, Tom Nemeth, who will also cover some logistical information.
Hey everybody, thank you for joining today. As Pam mentioned, welcome to the webinars, the third in our series. So today's panelists will include Dr. Iyer. Dr. Iyer is an interventional cardiologist here in Buffalo, specializing in structural heart interventions. His clinical practice includes general cardiology, interventional cardiology, and complex valvular heart diseases. He directs the Complex Valve Clinic at the Buffalo General Medical Center, as well as structural heart interventions at the Gates Vascular Institute and Buffalo General Hospital. Joining us today from Brigham and Women's Hospital in Boston, Massachusetts, are Dr. Shaw. Dr. Shaw is the director of the Interventional Cardiovascular Disease Training Program and director of the Cardiac Catheterization Labs at Brigham and Women's. He's a cardiovascular medicine specialist who is also an assistant professor of medicine at Harvard Medical School. He received his medical degree from Perelman School of Medicine at the University of Pennsylvania and completed an internal medicine residency at Brigham and Women's, where he served as chief medical resident. Dr. Shaw is board certified in cardiovascular diseases and interventional cardiology. His clinical interests include catheterization-based techniques for the treatment of complex valvular and structural heart disease, as well as complex coronary intervention. Dr. Shaw's practice focuses on transcatheter aortic valve replacement, mitral valve interventions, PFOASD closures, alcohol septal ablation for hypertrophic cardiomyopathy, and high-risk PCI cases. Along with Dr. Shaw, we would like to welcome Jonathan Burdick. Jonathan is the Senior Director for Business Operations, Surgical and Procedural Services at Brigham and Women's. He's a healthcare executive with 15 years experience in cardiology, endoscopy, and radiology hospital administration. Jonathan holds a master's degree in healthcare management from Cambridge College and a bachelor's degree in nuclear medicine technology from the State University of New York at Buffalo. Also joining us today is Jessica Distefano. Jessica is a physician assistant in the Division of Cardiac Surgery. Jessica has over 10 years of experience in the field of medicine. In her current role, she provides direct care, counseling, and teaching to the cardiac surgery and structural heart program populations and coordinates treatment plans for patients seen in the structural heart program. Jessica graduated from Yale University School of Medicine with her master's in medical science in physician associate and holds a bachelor's degree in kinesiology and exercise science from the University of New Hampshire. With that, I'm going to turn it over to Dr. Iyer, and we'll get started with the webinar.
Thank you so much, Pam and Tom. Thank you, Edwards, for sponsoring this webinar series. I'd like to thank the folks from Brigham for participating. With that, I'm going to turn it over to Jonathan, who's going to kick it off. Our goal has always been to understand how people have dealt with doing TAVR, which I think is an urgent procedure in most people. How are we doing it in the context of protecting our patients in the era of COVID, our providers being safe, as well as making sure that the patients who do need to be taken care of get their procedures in a timely and safe fashion. So with that, I'll turn it over to Jonathan. And for all the attendees, please feel free to interject on the chat box, and I will be monitoring and asking questions as we go along. Thank you again to the Brigham team.
Thank you, Dr. Iyer. Give me a moment here to start sharing my screen. Let's move that down. Okay. Perfect. Thank you again, everybody. Really glad to be with you this Friday afternoon. And I think we'll be hitting on all the components that Dr. Iyer mentioned as far as the objectives go. You can see them there. We'll just get right into it here and start to talk a little bit about TAVR at Brigham and Women's Hospital. This is our team. This is a couple years old at this point, 2018, when we completed our 1,000th Tavr. And I don't need to tell everybody on the line here the number of different roles that are involved in taking care of our patients who undergo Tavr. So it was a nice moment to celebrate there, and a good point to kind of reflect on the many different folks who interact and take care of our patients. From a numbers standpoint, at the Brigham, this is a high-level look at annual Tavr over the past many years, since 2010. As I mentioned, in 2018, we saw our 1,000th patient. The peak thus far in an annual basis was 2019, when there was 321 patients. 2020, our fiscal year that just finished, was at 267, of course, impacted by COVID. And that you can see in a little bit more detail here over the last 12 months. You can see this V shape right here, where the onset of COVID happened. Most of these 27 patients were cared for in the beginning part of March. In April, we only were able to perform 5 of the Tavrs, the most critical at that point. And we'll talk more about that shortly. This slide looks at the same Tavr by month in the blue, as well as our own hospital peak COVID census. So of course, March, we saw our first COVID patients here at our facility. The peak was in April, 171 patients. We are a part of a larger system, so there, from a system standpoint, there were many more. But here at our local facility, it was 171. And of course, in that same month, we saw the lowest number of Tavr patients at 5. And as things have progressed, it of course got better with time, and then has started to come up a little bit as far as COVID population goes. But in the last couple of months, we have returned to what I would say is normal Tavr volume in the mid-20s. We'll see what December has in store. Talking a little bit about, and a bit more in detail about what the experience was at the start of COVID at the Brigham, and as we thought about how to take care of our Tavr patients. March was the beginning, of course, and it really was, a step on the brakes in mid-March, where all from a system level, we removed all non-critical or life-saving procedures from the outpatient schedule for the next many months. And that was a drastic measure, but of course was done with the thought of reducing the inpatient census to take care of what could be a large surge. So in March, we went from 5 cath labs, which is normal operations, down to 2, so more than a 50% drop there. We also had to close the recovery room, which is adjacent to the cath lab. And so for those very few patients that we were able to take care of, we needed to find another way to care for them before the procedure and afterwards as well. April had the biggest impact of the months. And we saw the reassignment of many of our procedural staff and recovery staff to the inpatient floors or other new critical hospital operations. Roles just popped up overnight, such as on the inpatient floors, somebody that needed to watch those caring for COVID patients, how they put on their PPE and take it off in order to, maintain safety and decrease infection spread. There was also a COVID testing hotline that the system stood up. Our system has 75,000 employees, and our hospital has 13,000 employees. And so there was a large need to understand for any staff that was feeling ill, that needed to get tested, how to get tested, what were the results. And so many of our staff actually took part in that, as well as other roles as well. Big challenge with N95 in April. and other PPE inventory, but definitely the N95. There was some critical stock available to the system, but some of that stock turned out to be less than ideal. And so we needed, the system needed to make a massive effort in order to procure different N95s. And when we were able to procure them, of course, everybody knows, one N95 is not equivalent to all the others. So all of a sudden we needed to stand up 24-hour a day, 7-day a week fit testing clinics for any hospital staff that needed to use an N95, and the inventory that was available to them was running out. They needed a new one. They had to get fit tested first. So that we had to start, and was able to start that in April, thankfully. There was testing was a big challenge in April, especially both for patients and staff, both the amount of tests available as well as the turnaround time. However, universal masking, I feel like our facility was, and our system was ahead of the game as far as that goes. That happened in early April, and many people think that really helped keep the prevalence of COVID-19 in our staff relatively low. And so starting in early April, anyone setting foot on the campus, whether you're a patient or a staff, needed to have a mask at all times. In May, we did begin to see some recovery there. Some of our staff started to return, and we went from 2 rooms up to 3 rooms in May. The recovery room opened towards the end of May, and June saw that even more so. And by the end of June, we were up to full staff and full rooms, thankfully. And I would say end of June and July forward, we saw what we call here the safe care commitment, which I think initially focused on social distancing, decreasing the number of staff in rooms. Overnight you saw these big stickers pop up on conference rooms and other rooms, waiting rooms, drastically reducing the number of authorized staff in there, and furniture taken out of the room, protective barriers going up at every patient interaction site. I would say more recently, probably mid-summer, there's been a large focus on how to eat safely. I think as we learn more about the disease and how it's spread, there's really been a big focus on, unfortunately, not eating together at all. In the cafeteria, for example, tables of 4 are now tables of 2, and there's a big divider up right in the middle of the table. And there's signs that show whether or not it's been cleaned. So it's interesting to see that pop up. And finally, I'll just mention, along with the eating safely, we have a beautiful campus. We're very fortunate. But I think in the recent months, there's been thankfully, less of a focus on the beauty and more a focus on the practical. And so some of these spots where they're typically reserved for hospital celebrations and that sort of thing, they've suddenly become very sort of sterile, single eating environments that just kind of, they're safe and they're out of the way, but they're not nice to look at, and that's okay for right now. Obviously the focus is on safety here. We have food trucks outside that now come to the hospital on the campus to try to promote people getting outside. There's a large tent that you would see at like weddings that all of a sudden shows up in order to try to decrease transmission risk at the time of eating. So I think that's what I wanted to talk a little bit about as far as the initial impact and initial recovery stage. I think at this point I'll shift over to, I think Jess will take us through some priority scoring. Just see if Jess is on mute. Ooh.
Yep, I am.
Okay.
Sorry, can you hear me now?
Yes.
I'm just talking to myself. Okay, so at the beginning, when the cath labs had to shut down from 5 to 2, myself and Sarah, who's our other valve clinic coordinator, went through all of the pending patients for the 2 clinics and priority scored them so we could get the most critical patients in treated first, and other people who were a little safer to wait, we postponed their Tavr. So we used the following criteria to score people who were in, priority 1, were the people who we really needed to get treated first. So those were anyone who was currently admitted with severe AS, we treated them while they were here. Anyone who had worsening symptoms in the month prior to referral, or we had the clinic that I run with one of the other interventionalists. We had a couple patients who were at a lower priority, and when we checked in with them, their symptoms actually were getting worse, so we brought them in rather than having them wait. Anyone who had syncope with their AS, mean gradient greater than 60 or peak velocity greater than 5, decreasing ejection fraction, or if they were admitted with acute heart failure in the last 30 days. Priority 2 were less severe patients. So they were symptomatic, but without any of the critical features in priority 1. And the goal for them was to get them treated as soon as we could once hospital operations returned to normal. And then priority 3 was anyone with asymptomatic disease or just mild symptoms, and they were kind of last in line after priority 1 and 2 to get them in. So at the time, we were told we could start booking elective cases again in June. So we went through this whole priority scoring at the beginning of April, and anyone who could wait until June, we did give them a June date with the understanding that if things changed and we went back to normal operations before their June date, we would get them in sooner. But if not, then at least we were planning for June for their treatment.
Jess, how did you keep in touch with these patients in terms of monitoring their symptom over these 6-8 weeks? What frequency did you have like a pattern that you had developed?
Yeah, so it's actually on the next slide. If you can go to that, Jonathan, thanks. So for new consults,
I can take over, Jess, here.
Actually, wait. Yeah, I had it somewhere in here.
Yeah, it's coming. I rearranged a couple.
Did you move it? Oh, okay.
Yeah,
Sorry.
So maybe I'll just take over, and VJ, I'll come to your point here in a second. So I think it was very important for us, even though we had restrictions on being able to do procedures, which was understandable, that we at least kept the pipeline of patients up and running. So I don't think our clinic volume actually dropped during this time, but we did convert completely to virtual clinics. They had our meeting, which is basically recreated what we do in the actual in-person clinic on a virtual basis. So they would be scheduled to see the interventional cardiologist and the cardiac surgeon, usually back to back. So, like I said, our volumes remained very high during this time. The one thing we couldn't do is gather some of the other information that we need to gather, like the walk test and the KCCQs, although I do believe that we were able to get some of this information by mail later on or by telephone. In terms of imaging, we've always just relied on imaging from outside institutions when patients are coming to us. So we have a tremendous intake coordinator who can gather all that, and we can review all of that stuff remotely. So really our clinic didn't change that much at all. Now, the one thing that we do in our normal operation is that we'll get whatever imaging that we think we might need at the time of that initial clinic visit. And most of the times that's just a CT scan. So that is something that was different, because obviously these patients weren't getting their CT scans later if we thought they needed a Tavr sooner rather than later. If we thought they needed imaging and we thought they needed to be treated during this time period, we would consolidate it all to one hospital visit so that the patients would only have to come in once, get their tests, and go home. So, rarely they might need an echo or a dobutamine stress echo or something like that. But the CTAs were the Tavr CTs were done during that visit as well. And that also required some coordination with our radiology department because they too had limitations on what they were able to do because of COVID. So we had to prioritize our patients as being either priority 1 or priority 2 or 3, as Jessica just described, and then we would have to get radiology approval to get them done. But typically that wasn't an issue if the patients clinically needed the scan so that we could treat them quickly. The other thing that we eliminated, and quite honestly, this is our practice now, is that we rarely, if ever, did a coronary angiogram if they came to us without a coronary angiogram ahead of time. We would try to combine a coronary CTA at the time of the Tavr CT if the renal function was acceptable. Otherwise, we just didn't do them unless we thought that there was a ischemic issue that also definitively required treatment. But just the presence of incidental coronary disease, we didn't necessarily make it routine that we treated that before or at the time of Tavr. And if we did, we tried to combine the procedures, but the goal was to basically minimize the number of invasive procedures they needed. So coronary angiography really, we really just deferred altogether and just did it at the time of Tavr. Next slide, Jonathan. Sure. Yeah, and so the goal was to limit to one visit. In terms of the actual procedures, I have to say that for the cases that we did do during this time, I don't know that we changed things all that much at all. We've always been a conscious sedation institution, at least I should say always, but since 2014 is really when we started changing our practice. As I mentioned, we tried to combine the coronary angiogram and a PCI if necessary, but we actually deferred a lot of PCIs with the idea that if the coronary disease became a problem later on, we could deal with it later on, but that the key thing was getting the valve taken care of. And again, we do this now, but if we're really concerned that a patient is a super high risk for needing a pacemaker after Tavr, if they're coming in with long PR intervals, right bundle branch blocks, etc., we would make sure that EP was on board even before we did the procedure and try to schedule accordingly so that we could get a pacemaker placed the same day as the Tavr. So the patients would be consented for the pacemaker. Depending on what our volume is, EP could come and just do a pacemaker in the cath lab, or we could move them over to EP if necessary. That was, and again, we're doing that now. We have early ambulation protocols, as I know VJ does, and many of pretty much all the benchmark sites. And one of the things that often keeps patients in the hospital a little bit longer is getting that necessary day 1 echo for TVT reporting. We tried to move a lot of those to the same day, so they would have their Tavr in the morning and then get their echo several hours later. And we did not send patients home the same day. I know there were some institutions that took highly selected patients and actually sent them home the same day after Tavr. We still kept them home, kept them in the hospital overnight, really for rhythm monitoring and access monitoring, and tried to get them out the door as soon as possible the next morning.
A question about the coronary angiogram with Tavr, and I think one of the questions, especially in intermediate and low risk patients, becomes picking the appropriate pathway for them, surgery versus Tavr. And in the absence of coronary angiograms, how do we go about making that decision? I mean, this is something that comes up over and over again for us now because we are still sort of in that phase. Do we need to do an angiogram? Do we not need to do an angiogram? Is the CTA adequate? How did you address that during that time, or were you just doing only the higher risk patients?
That's a good question. So I should qualify that we do make it a policy now outside of COVID that if we're dealing with a low surgical risk patient, we do separate that coronary angiogram. So that, because as you said, or as you implied, if there is important coronary disease, that patient may be better off with surgery rather than having a PCI and Tavr. during this time period, I have to say that I can't specifically recall like a true classic low risk patient that we treated. I'm sure we probably did, but I just don't recall one. And again, our volumes were very low so during this time, so it's not like we were treating a lot of patients. But I think if we had a patient who we really thought needed to go, get their Tavr, and they were truly low risk, and their coronary anatomy could sway decision, we probably would have separated in that situation, or gotten a coronary CTA. And if we felt comfortable there wasn't significant coronary disease based on that, then we would move forward, with scheduling a Tavr. But my sense is that most of the patients that we treated during this time were more intermediate, high risk, sicker patients. I think oftentimes the low risk patients are ones that, no matter how bad their gradients are, I mean, we all see these biduspid patients walking around with gradients of 60 and they seem to be doing just fine. We kind of sat on them a little bit longer so that we could get them treated at a more optimal time period for the hospital.
One of the questions that came up in chat right now is a question about where do your patients typically go after the TAVR, and do they spend the night in the same unit, or do they go to a different unit?
Yeah, that's a good question. So our patients will spend a brief amount of time in our recovery room just for watching, and then they go up to a inpatient floor. That's what we do now. The recovery room was closed during the time of the worst part of COVID, mostly because it was going to be converted to an ICU, which fortunately never happened. And I have to say, I'm forgetting where we sent them, Jonathan. Where did we send the Tavrs after? They went to the PAC. That's right.
Yeah, that's right.
They went to the post-surgical unit, where there was capacity to take any of our cath lab patients. In fact, all of our cath lab patients went to the PACU, even the PCIs, because the recovery room was closed.
Jonathan, maybe you can answer this. Was there a clear delineation of COVID and non-COVID floors, or COVID and non-COVID ICUs?
Yes, there was a delineation, and that evolved over time as the COVID census changed.
And the last part, I guess, from my standpoint, were you insisting, I mean, I don't know what the rules were, but presumably all the patients who were getting scheduled for procedures, were they getting tested for COVID, and was that a challenge?
Yeah, and I'll hit on that at the end of the presentation. At the moment, we do test all AGP generating patients, including Tavr, 72 hours prior to procedure.
I had one other question that I think, Jonathan, you may be able to best answer. Is the question is, how is your facility handling COVID cost allocation? Have you heard of other facilities allocating the cost of COVID cases as a weighted cost across all revenue cost centers?
It's a good question. So there was a new cost center created called COVID Operations, and a lot of the costs that are not specific to a given department would go to that. So, for example, barriers that need to go up across the institution, that would be assigned there. Where it gets a little less clear, a little murky, is if let's say on the clinic side, if a particular barrier needs to go up in a particular clinic, a lot of times the clinic would own that cost. Of course, I would say there's generally an understanding on the finance side that this isn't something that could have really been planned for. So I don't think that there's really harm there, so to speak. But that's what I would say about that.
Good. I'll let you guys continue with your presentation. Thank you.
You can go to the next slide.
All right.
And then Jonathan, I'm sorry, Jessica, this is where, go ahead.
Yep. So the way we monitored everyone while they were waiting, so myself and the other clinic coordinator, we had a spreadsheet where we kept track of everyone who was waiting. And we called, we kind of split up the patients so that we would call them every other week. So every week we were calling someone, but we were calling each patient every other week. And our program coordinator would schedule it as a telephone visit on Epic, which is the medical record system we use. So it would be a reminder to us that like these were the patients we had to call, and we would check in with them. And we would go over again any concerning signs or symptoms, always reassure them to call us if they felt they were getting worse or they had any concerns, and we would get them in sooner. And if we did have a couple of patients who did have worsening symptoms while they were waiting, and we escalated them up to priority 1 and got them moved, their Tavr date moved sooner. And then for the follow-up appointments, we were limited with bringing people into clinic, obviously because of the way the situation at the hospital was. So we did virtual visits for 30-day and 1-year follow-ups. So we did the KCCQs over the phone. If they could get a local echo at either their primary cardiologist office or facility near them that was still doing elective echoes, we would have them do it there and then send us the results. A lot of places, including Brigham, were not doing routine echoes during this time just for PPE use. And so we would schedule them as soon as we could after things returned to normal. And again, our program director kind of kept a list of who still needed their echo and scheduled them in the future when we thought operations were going to return to normal. And then even though we already had done their 30-day visit, we called them with the results and went over it again with them. The TBT was a little lenient with things being out of the window just because of the nature of, the situation. So that's kind of how we handle the follow-ups to limit, patient having to come into the hospital and obviously staff from having to be exposed. We're still doing 1-year visits for people who live far away virtually. And it's the same thing if they have a local echo that they've had done with their primary cardiologist and lab work, we'll just review it at the time of the visit. So that's kind of a change to our practice as a result of COVID. That's working out well. People really appreciate not having to drive all the way into Boston, especially if they live far. So there's one good thing that came out of it, I guess.
Did you have any patients who you guys felt were in priority 1 that, despite your advice, preferred not to get treated? I mean, did you have a bunch of those, or?
No, I would say that.
I don't think yeah.
I would say that when these people were not doing well or feeling badly, they were more than happy to come in and get this done, and they weren't too worried about COVID. I don't recall any patient during this time period who fought coming in when we recommended it because of the concern for COVID. I will say though that once things kind of lifted, I feel like we were getting a lot more of that. And one of the things that was a little concerning, and when Jonathan showed our initial volume slides, we had that dip down to 5 cases in April, and March, we were shut down in the middle of March, and even despite that, we managed to do something like 27 cases. So we were on pace to have a huge month. And then, April happened, and then come May, we were slowly starting to, come back up. And then by June, we had pretty much gotten through our, through the month of June, we'd gotten through our backlog. But interestingly, July, August, September, our numbers were actually quite low. And I didn't exactly know how to explain it. Our clinic numbers were also low. And interestingly, our clinic volume was much higher during the actual COVID than it was after COVID. So I do think there was a concern of patients, coming into the hospital more so afterwards, and they probably just weren't even seeing their primary care doctors or their cardiologist for them to actually make the referral to our clinic. So that I would just say in the last maybe month, would you say, Jessica, I think has started to turn around. That doesn't seem to mirror what I've heard from other people around the country. It seems like when they bounced back, they were back to normal. But talking to colleagues around Boston, it seems like that trend that we noticed here may not have been different from other institutions in town.
Yeah, I know we had one patient in our clinic that I think she was scheduled for September. So it was like well after the beginning of the surge. And she was someone who had been postponed from the spring. And this is just her, I don't know if there's other people, like no one in her family wanted to even come into the city because you just hear that Boston, the numbers were high. It's like they didn't even want to come anywhere near the city. And so she kept pushing it out and she couldn't drive herself. So she was relying on people. So I think some of it was people just also didn't want to come in to Boston because numbers were higher in the city than maybe the suburbs where they lived. So
What is your normal turnaround time pre-COVID from initial patient contact to actually getting the procedure done?
It's about 3 weeks. When you say
Yeah.
it's about 3 weeks.
And what kind of normal backlog or a waiting list do you normally have? And how was that different during COVID, both your turnaround and your waiting list?
During COVID, I would say that certainly our waiting list got longer because we were restricted. But I have to say that by middle to end of June, we had gotten through the patients that we had deferred. We had seen patients during COVID who we decided to schedule later because we thought they could wait. So they were scheduled maybe July, August. So intentionally pushing them out. But now, we're back to sort of being able to get patients scheduled within 3 to 4 weeks. They can get clinic visits within 2 weeks usually. Yeah, so I mean, I think we're back to normal. Hopefully it stays, but everything did get pushed back, just because we didn't have the capacity to bring patients in or do procedures on them.
Could either one of you talk a little bit about visitation rules in Boston during COVID, post-COVID, and the impact that has on elderly patients wanting to come in or not wanting to come in, and the comfort that they have going through a procedure like that without anybody next to them?
Yeah, Jessica, you took some of those phone calls, I know.
Yeah. So initially, during the initial surge, April, May, there was no visitors allowed in the hospital at all. So that was difficult. I mean, we had one patient who spoke like a very specific Arabic dialect that we didn't have any in-person interpretation for. And they were going to have to use, I think, one of those iPad interpreters. And I worked for a week on trying to get approval for her daughter to come in and translate. And the daughter said, I'll stay in the room with her. I won't even go to the cafeteria to eat. I'll wear a mask the whole time. Like, she just can't be alone. And it got approved. It had to get approved by each procedural unit. So the pre-procedural unit approved it. The PACU, where she was going to recover, approved it. And then the nursing director on that floor said no. So she ended up having it done anyway. I think they were lucky that a nursing aide on the floor spoke the language, which just was lucky, but she got through it. But a lot of people, I think, especially the elderly people, were concerned. But I think if they were told they needed to have it done, they would agree. And we tell them, you're only over one night, so should be discharged the next day. It's not like a long hospital stay like for open heart surgery. And then I think around June, they loosened the visitor policy a little bit. And right now it's one visitor for 2 hours a day between the hours of 1 and 8 p.m. So that's more, I don't think people have too much of an issue with that, because as long as they know someone can come see them, they're okay being alone the rest of the time. What's difficult is we used to do the procedures, or we do the procedures, but the floors the patients used to go on are in the cardiovascular building, and it's all private rooms, and they pull out couches. So a big selling point before COVID was you can have your family stay with you. They can sleep overnight. It's a private room. They can stay. And now obviously there's still private rooms, but the hospital doesn't allow the overnight visitors. So
that, and actually our cardiovascular center became the COVID center.
Right. Yeah.
It was a newer building and every room was negative airflow. So patients had to move over to the older part of the hospital, which isn't nearly as nice. But yeah, I think that was a huge issue for a lot of patients, particularly the elderly. I mean, I couldn't imagine my mother or father coming in for a procedure like that, and not having a family member being able to see them, and basically drop them off at the front door. Somebody escorts them through their process, and then somebody brings them back downstairs and you pick them up. And that's a lot to ask for, for a 8-year-old to go through, I think.
Yeah, I mean, that continues to be a concern for us here because we have still very strict visitation rules and probably getting stricter with the research. So, well, thank you for those answers, and I'll let you continue with your presentation.
Great. All right, so I think just click on this here. So we talked a lot about COVID and the initial recovery. I'll just finish this off here by talking about more, bring this up to current state, current date, and then we'll finish things off. So this is each of these are a couple days old. Just looking at the daily confirmed cases. Everybody's seen these charts, but somewhat interesting to look at Massachusetts. So you can see, of course, here the confirmed cases are going up. This is, as I said, a couple days old. Just yesterday, we had the highest number recorded, and that was that actually would be off this chart. It would be 6,000, so somewhere up here. So definitely going up. Hospitalizations across the state also going up, of course. You can see there. This is the TPH dashboard. 7-day positivity rate right now is near 5%, up from 1 or 2 in September. Age breakdown of COVID, the highest being 20 to 29-year-olds, followed by 0 to 19-year-olds. And probably the two of the more important charts for us as we think about Tavr is just the total hospital capacity by region. And the state breaks this up not only into 6 different regions, including Boston, which is circled here on both, but also non-ICU and ICU. You can see non-ICU is really where the reduced capacity is showing up. This number here, 24%, is going down each day as time goes on. And just yesterday, the Department of Public Health raised the tier for our region to tier 2, indicating we need to start to take a look at reducing inpatient bed census in a voluntary manner. So we'll be talking more about that next week, I'm sure. ICU, it looks like there's a decent amount of capacity, at least as of Wednesday.
At what stage does it start to impact your ability to do inpatient procedures?
So I think this is probably the thing that's going to trigger things first. As that gets down to, I don't know what the threshold is, but I would think it's somewhere around the high teens. That's where we'd be asked. And at this point, we do everything as a system. So our system would likely take a very similar approach across the facilities in either, reducing procedures in general to free up staffing to go to floors to, take care of the COVID surge patients, or potentially focusing in on procedures that would include an admission overnight in order to target a reduced bed strain as well. But we're getting close to having to do one of those two things.
Last time around, one of the major drivers for minimizing elective procedures was the availability of PPE. Mm-hmm. And is that still an issue in the Boston area?
Thankfully, well, I can't speak for the whole Boston area, but I think from our system, the MGB system, that is not a concern at this moment. There was an update last week, sort of going through the number of different items, and in general, there's a good stock on hand, at least for the next many months. This is the actual COVID census by day at Brigham and Women's Hospital. So the peak began 171 in April. Most recent data on this, I think, was December 1st at 36. Today, I think it's actually in the mid 40s. So definitely increasing there. And the final slide I have is just talking through our current state. we touched on a few of these, so I won't go through all of them. But so currently we do pre-procedural COVID testing on all patients undergoing AGP, including Tavr, within 72 hours. I think that's one thing our system has done fairly well. We've set up a number of offsite locations in the greater Boston area that are in some manner open 7 days a week. It's not perfect by any stretch, but patients can go usually someplace close to home prior to their Tavr in order to get the test done and results back usually within 36 to 48 hours. PPE, as I mentioned, generally available. No concerns, especially not to the degree as it was in March and April, especially. Big focus on employee health. We definitely do look at the incidence of COVID-19 within all of our staff, and when compared to the community, it is lower, which is good. However, there was a cluster on one of our inpatient floors in September that did lead to the need to really test our employees, have the ability to test our employees even more efficiently than we were doing before. So we actually took two of the nicest conference rooms on the campus, and they are now testing sites, walk-in testing sites for any staff that wants to get tested. At this point, it's 3 days a week, but we're probably going to move to 7 days a week shortly. And so that was a good development to come of this, to make it easy for staff to get tested. Masking, of course, is required. We talked about that. And more recently, essentially in all parts of Massachusetts and in public life, masks are required, and there's pretty good compliance with that, I would say. The non-traditional spots on campus being converted to for employee eating. We talked about that. One other thing every employee has to do every single day before they step foot on campus is they open up an app on their phone and they look at all the different symptoms, and they have to say, I'm not having any symptoms. And if they are having any symptom, there's a very low threshold to say to the person they need to stay home. Of course, there's an element of trust there, but in any degree, it is good to at least think about. I would say there's a good amount of HR support for any employee that is affected. Benefit time is not required to be used if there is an unfortunate case where somebody gets it, or support for the family if that happens as well. And thankfully, we've been able to avoid any kind of layoff or furlough, at least for hourly workers. To this point, which is good. Not all hospitals in Boston have been able to do that, but thankful that we haven't had to. And the testing availability I touched on already.
I'll make one comment about who we test. Yeah, if you're undergoing an aerosol generating procedure, so if they're going to get intubated,
right,
get tested. I think the only reason we're doing the Tavrs is because I think anyone who's anticipated to stay overnight has to get tested, right? But for our typical cath cases, PCIs that we expect to come in and go home the same day, they don't require testing. Unless they're getting a procedure under general anesthesia and planning to go home the same day, then they'll get tested. And then, I will say, in terms of the employee testing, I think they've done a pretty good job with that. I actually just happened to walk by it yesterday, and I said, what the heck, I'll go get tested. So I just showed up, had no appointment, didn't need one, and it literally took 3 minutes. And actually, that was at 10 a.m. and I got my answer back, at 2 o'clock this afternoon. So I think that's great. I think quite honestly, the only way to until we get a vaccine is to, the more you test and the more you know where you stand, I think the safer you can be, or at least for protecting your colleagues and your patients. So, because of course, I think if we ended up testing positive, then I think you're basically out of the hospital for a good 10 days.
Right. Could you talk a little bit about vendors coming into your cath lab and testing for them, or what the requirements were for them for coming in, and how were you regulating that?
Yeah, they were asked not to come during the peak of it, and now if a physician felt they absolutely needed a vendor there, then we could have them there. So you know, I think we can actually generally do Edwards valves without a vendor. So in fact, I think for the cases that we did during April, we did not have a vendor there. Our staff's pretty well trained in prepping the valve, et cetera. You know, I know I believe we had one inpatient mitral clip that we had to do. And of course, you know, I think we still like to have the vendors there for that. So we, you know, if we felt that they needed to be there, then we were able to bring them in. I don't know, Jonathan, can you comment at all about the testing policy for the vendors right now?
Yeah, so they definitely need to attest if they come on campus, whether or not they have any symptoms. They have to be masked. If they live within the state, there's no testing requirement that they have to undergo. But if they travel from any other state, they do have to have a negative test within 72 hours prior to coming on site.
Yeah, and actually that's another issue too for, you know, Massachusetts has this quarantine policy for patients coming in from out of state, which of course, yeah, I think is virtually impossible to enforce. But, you know, if you come in from out of state, then you have to quarantine or come up with a negative test, which, you know, biologically may not make a lot of sense because you probably, you know, may not get positive until several days later. But that's the way they have it, and that's fine. But we have had an issue now because we get a lot of patients from Rhode Island, which is literally, you know, 30 miles from here. But if you happen to live 31 miles from here in Rhode Island, you can't come into this hospital unless you have documentation that you have a negative COVID test within 72 hours. So that's been an issue for some of our patients and their families coming from Rhode Island to get treated here.
Mm-hmm. Thank you.
All right. So I think that actually finishes off the slide here. So I will stop sharing.
Excellent. I guess this is a great opportunity to open up for anybody who may have any questions on the chat line. I think I've peppered them with enough questions of my own, so I'd be happy to take any from anybody else. If there's no additional thought. So as we are sort of in an Edwards benchmark thing, I know, you know, we're sort of the benchmark sites sort of all do the same thing more or less at this point in terms of how we screen patients and how long we expect them to stay. In retrospect, the fact that you were already sort of a benchmark site and we're doing things in a sort of a lean fashion, do you think that helped you deal with this whole crisis a little bit better? And for each one of you, if you had to say, take 3 take-home messages that, how would you change? Are there things that you started doing in COVID that you think you're going to do forever now in your program?
Yeah, I think the number one thing has been the virtual visits, and I think that's something that's going to be here to stay. I know some physicians don't like it. I mean, I would prefer to meet the patient in person, but I actually don't mind it so much. I mean, there are some things that you're going to lose. You know, can't really examine the patient. I would say that it's rare that the exam changes the big picture, I think, particularly when we're talking about aortic stenosis and Tavr, but sometimes it's important. I do think what's important is being able to see the patient and get a sense of what their frailty is like, and that might be a little bit harder over a video, although I do think on a video, you know, you can get a lot of that. You know, oftentimes the patients are, you know, I saw a patient recently who had gastric bypass surgery a long time ago and weighed 274 pounds. And of course, I was just looking at her face. And I was a little awkward to ask her, can you stand up for me for a second? So, you know, because those things are important as you're assessing a patient for a procedure like this. So you do lose some of that. But I think it's great for the patients because I think, you know, particularly for the elderly patients, it's hard to come into Boston. You know, you have to fight the traffic. Everyone's very concerned about driving here, and then you get here and, you know, you have to pay $30 to park your car, and that's not fun either. So, and I think the valve follow-ups will be a lot simpler, I think, with virtual visits at 30 days and 1 year that we have mandated to do. I think it makes it a lot easier, you know, to get the information we need to meet registry requirements and just keep up with our patients. So I think that's going to be really important. going forward. In terms of your comment about the being a benchmark site and doing the things for rapid treatment and efficiency, I don't know that there's a whole lot that we did differently during COVID than we were doing before. And if anything, I think it kind of reinforced some of our practices. I really do think one of the big areas that's changing is how we manage coronary disease in Tavr patients, provided I'm talking, certainly high risk and maybe most intermediate risk. I think low risk, we have to be a little bit more careful and be careful about how we manage it. But I think the majority of coronary disease that we come across in Tavr patients can be safely left alone. The times that I'll think about treating it is if I feel like they're having, chest pain or a really good ischemic story and I can't tell what's what, I might treat it at that point. If I'm really concerned based on their anatomy or the choice of valve that we're going to use, that getting back into that coronary is going to be a little bit more of a challenge. I might have a lower threshold to treat it if I think it's potentially problematic. But for the most part, we leave our coronary disease behind. I think that saves the patient another trip, another procedure to the cath lab, and just enables us to get them scheduled much more sooner. But yeah, I don't know that there's much else about our practice. I mean, I think an intriguing thought is, can we think about coming up with criteria for who is a good patient to go home the same day after Tavr? And I know sites have done it. I don't know, Vijay, were you doing this at all?
We've done those patients who already had permanent pacemakers, and we felt that the groins were not going to be an issue. We sent them home. I still have concerns about sending patients home, especially from the conduction issue standpoint. We also, just like you, we get patients from 90 miles away, and sending them home, and if they have a problem, it's not an easy fix for them to just come back in. So those are things that we worry about. But if they live close by, they have reasonable support, I don't expect a conduction issue, or they already have a pacemaker. Those we have sent home same day.
Yeah. I mean, I have to say I'm a less, sort of enthusiastic about that aspect of it. I mean, I feel like we've brought aortic valve replacement from 7 days in the hospital to 1. That's a pretty darn good, victory. Going from 1 to 0, is it really worth it? And I just don't know that it is. But we said that about PCI for a long time, and now it's the rare patient that stays overnight anymore. So I'm sure we'll get there.
Yeah. Just anything that you think you learned from your experience that you want to keep going forward, and things that you wish were absolutely, you want them back?
I agree with Dr. Shah that the virtual visits, I think, are definitely something we'll keep. It's hard for us sometimes to get people back for that 1 year visit. I think the 30-day, they just had a procedure, so they're willing to follow up with us. But a year after, especially if they have a relationship with another cardiologist, they used to no-show for appointments a lot, or they would, not want to come because it's like he said, people don't want to drive into Boston. So I think being able to offer that, people would be more willing to follow up with us. I don't know. I think that's probably like one of the best things that came out of this.
Jonathan, from an administrative standpoint, and the way you allocate resources and how you think about personnel, flow of patients, contribution margins, has this experience changed the way you think about it? Because it seems like we all got to figuring out that we could do Tavr a lot leaner than we ever thought we needed to.
Yeah, as Dr. Shah said, I feel like we were pretty lean even before COVID, and it was great to see that, getting through it, there was no difference in outcomes. So, we'll continue to focus on that lean aspect of it. As far as something that I'm looking forward to coming back, I would say visitors. Once this is all over, having somebody, accompany our Tavr patients through the day will be fun, or will be nice. And as Jess mentioned, having them stay overnight, with their loved one is very important. So looking forward to having that back. And then the other comment I would say, what we gained from this, I'm just astounded at, if you told me in February that, this would be upon us, and, our staff would essentially overnight, need to put on different hats and go to a different part of the hospital and work for somebody else, and all at the same time trying to, keep things going at home. The amount of flexibility that our staff has shown and responsiveness, I think, has just been amazing. Hoping to keep that.
If I don't see any further questions in chat, and it's at 4:30, it's Friday evening. If nobody has any further questions, I really thank you folks for taking the time out of, I'm sure, very busy days to do this. On behalf of the Jacobs Institute and Edwards, thank you all. Thank you all for attending. And with that, we will sign off and give you back the rest of your time. Thank you so much. Have a great weekend, folks. Be safe.
Thank you.
Bye.
Hey, everyone. Thank you.
Thanks.
Appreciate
Thank
it.
you all.